Bismillah ar-Rahman ar-Rahim. The topic of our lecture today is benign tumor of the ovary. Background. Benign ovarian cysts are common, frequently asymptomatic, and often resolve spontaneously. 90% of all ovarian tumors are benign, although this varies with age. Of the tumor that require surgery, 13%, some references up to 20% in premenopausal women are malignant. But if we deal with ovarian tumor in postmenopausal women, 1 out of 2 of them, they are malignant. So the possibility to be malignant increases with age. The main objective of management are to exclude malignancy, to avoid cyst accident, which include hemorrhage, torsions, or rupture and infection, without causing undue morbidity or mortality or impaired future fertility if the tumor occur in young age women. Ovarian tumor may be physiological or pathological and may arise from any ovarian tissue, whether from the surface epithelium, whether from the stroma, or whether from the germ cells. Most benign ovarian tumors are cystic, but the finding of solid elements make malignancy more likely. However, fibroma, teratoma, dermoid, Brenner tumor, although they are benign, but they have a solid elements. Now, if we see this picture, we will see that the tumors arising from the germ cells, we call it germ cell tumor, arising from the epithelial layer, we call it epithelial cell tumor, arising from the stroma, we call them stromal cell tumor, whether benign or malignant. And all these names we will speak about in details in the coming 2 lectures. Pathology of ovarian tumor. It includes physiological cyst, as we said, or pathological. Physiological cyst may be follicular cyst, corpus luteal cyst, theca luteal cyst. But pathological include those arise from the germ cells. We call it a benign germ cells tumor, which include dermoid cyst, mature teratoma, or arise from the epithelial tumors, which include serous cyst adenoma, mucinous cyst adenoma, endometrioid, Brenner, and clear cells tumor. Benign sex-core stromal tumor, which include granulose cells, theca cells, and fibroma, sertoli Leydig cells tumor, or it may be inflammatory, which include tubo-ovarian abscess or endometrioma. Coming to the physiological cysts, they are common and they occur during normal ovarian or menstrual cycle. And most are asymptomatic and discovered incidentally during ultrasound examination. And the treatment is conservative. First one of these physiological cysts is follicular cyst. It is the most common benign ovarian tumor and is often found incidentally. It can persist for several menstrual cycles and may reach different size and even may reach up to 10 centimeters. When to intervene if symptoms develop, mainly because of complication, acute presentation, or if it persists for several menstrual cycles. And up to, it varies with guidelines. Some said 3 months, some said 6 months, some even up to 1 year. Occasionally, they may continue to produce estrogen, causing menstrual disturbances and endometrial hyperplasia. Why? Because it is lined by granulose cells. The second one is a luteal cyst. It is less common than follicular cyst. The size of it more than 3 centimeters, usually on the right side. That's why it may mimic features of appendicitis. And if they present usually at day 20 to 26 of the cycle, and if they bleed or because they have rupture, they may mimic appendicitis, as we said. Coming to the first pathological type of ovarian tumor arising from the germ cells, called germ cell tumor. And the common one of them are benign germ cell tumor. Benign germ cell tumor is the commonest ovarian tumor, occurs in women less than 30 years of age. The risk of malignancy is low, 3%, but 30% of them will be malignant if it occurs in women less than 20 years of ages. They are usually cystic but may contain solid elements. They are of 2 types, either cystic teratoma, mature cystic teratoma, or mature solid teratoma. Immature goes with malignancy. Coming to the first one, which is mature cystic teratoma. It is common, forms around 40% of all ovarian tumor, occurs in young age group, and the median age of presentation is 30. It results from differentiations of embryonic tissue, which include endoderm, mesoderm, and ectoderm. Mainly ectoderm may be bilateral in up to 10% of the cases, usually unilocular, and the size of it varies, but usually less than 15 centimeter in diameter. There is type of it, we call it monodermal teratoma, which is teratoma with single type of tissue, and it is of two types. Primary carcinoid tumor of the ovary, which give rise to 30% of cases to carcinoid symptoms and rarely metastasize. And second one we call stromal ovary, which is predominantly composed of thyroid tissue. Then it forms about 1.4% of cystic teratoma, can produce estrogen in up to 5 to 6% of cases, and malignant to be malignant up to 10% of cases. What are the complications of mature cystic teratoma? Torsion, rupture leading to severe form of chemical peritonitis, and this complication usually seen during pregnancy, and it may be malignant in up to 3% of cases, especially if it occurs in women more than 40 years of age. This picture shows dermoid, as we said, mainly from ectodermal origin. That's why it contains teeth and tissue, hair tissue. Mature solid teratoma, they are rare, and we have to differentiate it between immature teratoma, which is malignant, as we will see in the next lecture. Coming to the second type, we call it benign epithelial tumor. The majority of ovarian tumor, both benign and malignant, arise from ovarian surface epithelium. They are therefore mesothelial in nature, derived from the coelomic epithelium overlying embryonic gonadal ridge, from which Mullerian and Wolfram structures develop. Therefore, this may result in development along, if it arises from endocervical, give rise to mucinous cyst adenoma, endometrial give rise to endometrioid, tubal give rise to serous cyst adenoma, and duroepithelial tissue give rise to Brenner tumor. This picture shows the origins of it according to the coelomic epithelium covering the women's reproductive system. First one is serous cyst adenoma. It is the most common benign epithelial tumor, may be bilateral, usually unilocular, with papilliferous processes on the inner surface, and mainly on the inner surface, but maybe on the outer surface. The epithelium of them is cuboidal or columnar and may be even ciliated. The fluid secreted is thin and serous, and they are seldomly as large as mucinous tumor. This shows serous cyst adenoma. Mucinous cyst adenoma is the second most common epithelial ovarian tumor. They are usually large, unilateral, multilocular cysts with a smooth inner surface. The lining epithelium are of columnar cells, but produce mucus fluid, so the fluid is thick and gelatinous. This shows mucinous cyst adenoma. Coming to benign epithelial tumor, it is very difficult to differentiate between it and ovarian endometriosis. Brenner tumor, it is rare, may be bilateral. They are benign in the majority of cases, but still may be malignant, mainly of borderline. It occurs in women above 40 years of ages. They are small, and they may secrete estrogen, causing abnormal uterine bleeding. Brenner tumor usually yellow in color because they secrete steroids or hormones. Clear cells tumor, they are rarely benign, and mentions here why? Because it occurs in young age group and carries good prognosis if diagnosed early. Last one is benign sex cord stromal tumors. It represents only 4% of benign ovarian tumor. It occurs in any age group, may secrete hormone, and presents with the results of inappropriate hormonal effects. First one of them, we call it Granulose cell tumor. They are malignant, but mentions here because it carries a good prognosis. They do grow very slowly, and the recurrence is seen 10 to 20 years later. They are large solids. They produce estrogen or inhibin, and this is tumor markers of it. Cole-Exner bodies are pathognomonic but are seen in less than 50% of cases. Second one is theca cells tumor. They are benign, solid unilateral, occurs in women more than 60 years of age. Again, they secrete estrogen and they manifest in different age group with a precocious puberty, postmenopausal bleeding, endometrial hyperplasia, which may lead to endometrial cancer. And they rarely cause ascites or pleural effusion, although they are benign. Third one is fibroma. They are hard from its name, but mobile and lobulated, occurs in women around 50. They are bilateral in up to 10% of cases, may be associated again with ascites, and if it was associated with ascites and pleural effusion, we call it mixed syndrome, but this is seen only in 1% of the cases. Sertolizing cells tumor, they are of low-grade malignancy, that's why mentioned here, occurs in 30 years of ages, but they are rare. They may produce androgen with androgenic manifestation, and some of them secrete estrogen. They are generally small and unilateral. Age distribution of ovarian tumor. In younger females, the most common benign ovarian tumor are germ cell tumor. But in elderly age group, they are epithelial cell tumor. How the woman with ovarian tumor presents may be asymptomatic. They may present with pain, with swelling, because of pressure effect, because of menstrual cycle disturbances, because of hormonal effect as in androgenic ovarian tumor, and they may present with abnormal cervical smear because of the origin of these tumors. So the differential diagnosis of ovarian tumor depends on the manifestations of it. If it was pain, ectopic pregnancy, abortion, PID, appendicitis, Michel's diverticulum. If it was abdominal swelling, maybe because fibroid or distended bowel or ovarian malignancy, colorectal carcinoma, lymphoma, because of pressure effect, because of hormonal effect, or because of complications on its own as hemorrhage, rupture, infections, and torsion. The most important complication is torsion. Ovarian or adnexial torsion is infrequent but significant cause of acute lower abdominal pain in women. This condition is associated with reduced venous return from the ovary as a result of stromal edema, internal hemorrhage, and hyperstimulation or a mass. The ovary and fallopian tube are typically involved. Quick and confident diagnosis is required to save the adnexial structure from infarction. Ultrasound with color Doppler is the mainstay or is the cornerstone in the diagnosis, and treatment is imminent either by laphotomy or laparoscopy, and this shows adnexial torsion. How we investigate a woman with ovarian tumor. The investigation required will depend upon the circumstances of the presentation. Patient presents with acute manifestation needs imminent intervention, while asymptomatic patients or those with chronic problem may benefit from more detailed preliminary assessment. We have to take a full history. We have to do a proper examinations from head to foot, including breast, neck, axillary lymph node examinations, and chest to exclude pleural effusion. The cornerstone investigation is ultrasound, and better to perform transvaginal or transabdominal ultrasound. And there are specific features of ultrasound goes with benign, and specific features of ultrasound goes with malignant. To see solid tumor, bilateral, free fluid, lymph node involvement with increased vascularity by Doppler and large-sized tumors, these features goes with malignant. Other investigations include chest X-ray, abdominal X-ray, barium enema, in addition to other investigation as full blood count and film. Tumor markers is very important, as we will see in next lecture, which includes CA125, beta-HCG, estradiol, androgen, and alpha-fetoprotein, and serum inhibin. Management depend on the age, depends on the presentation, and depends whether the woman wants pregnancy, further pregnancy or not. If the woman was asymptomatic and elderly age, we have to exclude malignancy as we said. And again, the woman, she doesn't need further pregnancy. That's why preservation of ovaries is not the priority for her. If we deal with a mass more than 5, especially if it was more than 5 centimeter in diameter, we have to exclude malignancy as we said, because the possibility to be physiological is low. As we said, 1 out of 2 may be malignant. That's why it is mandatory to exclude malignancy. We use risk of malignancy index should be used to select those women who require surgery. And the risk of malignancy index, as we know, equation include ultrasound feature, menopausal state, and CA125. We will multiply all these parameters to get out with a score. If it is less than 25, low risk to be malignant, between 25 to 225, moderate, and if it was more than 225, it is high risk to be malignant. If the tumor markers was low, if the ultrasound features was simple, and if she was a premenopausal state, this goes with low risk to be malignant. If all 3 criteria present, then the ovarian cysts are likely to be benign and may be managed conservatively. If there is no change in the cyst in the second ultrasound and 3-month follow-up with 6-month ultrasound and CA125 estimation is safe. The role of laparoscopical surgery in the assessment and treatment of apparently benign cysts in this age group is controversial, so we have to be very cautious when we use laparoscopy in the management of ovarian tumor in postmenopausal women. If she was premenopause, especially if she wished to be pregnant, the risk of malignancy, as we said, is low. And if we find a clear unilateral cyst less than 10 centimeters in diameters, we can follow the woman by ultrasounds with 3-month interval, especially if the ultrasound features, as we said, goes with benign and CA125 was normal. If the size increased, laparoscopy or laparotomy may be indicated. What about features of ultrasounds goes with benign? If it was unilateral, unilocular, clear fluids, if the size of it was less than 10 centimeters, if she was premenopause, less than 6 centimeters, if she was postmenopause, if the CA125 was normal, and there is no free fluid or omental seeds or matted bowel loop. This is, there is thick fluid with septations and internal echoes. It is complicated, as we said, ovarian tumor. If the woman presents with symptoms and it was severe, so emergency laparotomy or laparoscopy is necessary. If it was a chronic symptoms, we can go for further investigation. Surgery of ovarian cysts may include ovarian cystectomy, or oophorectomy, or adenectomy according to the circumstances and again according to the age. If the woman was pregnant and presents with ovarian tumor, the possibility to undergo complication is high, whether by torsion or bleeding. If it occurs in the 3rd trimester, it may affect engagement of the presenting part, or it may be asymptomatic, discovered incidentally during ultrasound examinations or at the time of cesarean section. No place to postpone operation if it was acute abdomen. If asymptomatic, it is wise to wait until 14 weeks, even up to 16 weeks, before removing it to avoid the risk of removing a corpus luteal cyst, which is necessary to maintain a pregnancy. If cyst unresolved, 6-week postpartum surgery is undertaken because there is an increased possibility to have complication. Ovarian cancer is uncommon during pregnancy, occur in less than 3% of cases. However, a cyst with features suggestive of malignancy on ultrasound or one that is growing very rapidly should be removed surgically. CA125, we cannot rely on it because it is normally elevated during pregnancy, and if there is suspicions of malignancy, especially if we use the frozen section, it may necessitate cesarean hysterectomy with bilateral salpingio-oophorectomy and omentectomy. Thank you so much.